Please take your seats as the session is about to begin.
Hi, good afternoon, everyone. I'm Lisa Sanders, and I have the privilege of serving as the Executive Director of the American Heart Association's Healthcare by Food initiative. And I'm delighted to welcome you here today and welcome you to this session, What is Food is Medicine, and How Healthy Food Through Healthcare Can Address Chronic Disease. So we're here to tackle a simple but profound idea, the inextricable link between diet and chronic disease. Too often, our healthcare system treats illness without addressing its root cause, poor nutrition. So Food is Medicine seeks to change that by making healthy food accessible and a core part of prevention, treatment, and disease management. At its core, Food is Medicine is distinct from broader nutrition and food security efforts. And while those policies are essential to improving health and addressing hunger, FEM interventions specifically focus on the integration of medically tailored meals, medically tailored groceries, and produce prescriptions and other interventions into the clinical care system. Its components, which are rather distinct and complementary to a lot of social support programs. So this conversation today will also touch on the policy landscape around this and the policy landscape that's changing and shaping the future of FEM, as well as the evidence that is so critical and still needed to demonstrate the effectiveness and clinical and cost effectiveness of these interventions. But to truly make the case here, we must show not just that these programs improve health outcomes, but also that they reduce costs for payers and frankly, that they work. So we're fortunate to have with us today two leaders who bring unique perspectives on this work. Dr. Kevin Volpe from the University of Pennsylvania, a leading researcher on the science and economics of behavior change and incentives in healthcare. Dr. Volpe is the science lead of the Healthcare by Food initiative for the American Heart Association, but he's also the founding director of the Center for Health Incentives and Behavioral Economics, where his work focuses on developing and testing innovative ways of applying insights from behavioral economics in improving patient health behavior and affecting provider performance. We also have with us today Ms. Elizabeth Yee, representing the Rockefeller Foundation, which has been at the forefront of catalyzing investment and action in the food is medicine space. Ms. Yee is Executive Vice President of Programs, overseeing global programs, regional offices, partnerships, and learning and impact for the foundation. And with that, I'll turn it over to Liz to get us started.
Thanks, Lisa. I had to check my watch. A very good afternoon to all of you, and thanks for making the time to join us for this session. And thank you, both Lisa, Kevin, and the entire American Heart Association team for making this healthcare by food such a priority. I just thought I'd start by sharing a story. This is a gentleman named Merlin Jones, and I had the pleasure with my colleague Charlotte to be in Tulsa about a month ago. And I don't know how many of you or if any of you are from Tulsa, but I was specifically in the community of North Tulsa. And if you haven't been there, what you'll realize is that North Tulsa is a food desert. It's very hard to get access to fresh, good food. And so while I was there, I met Merlin. This is Merlin. And Merlin, before being part of a program called Fresh RX, had to travel miles and miles to actually get to a grocery store. And Merlin also has type 2 diabetes. And so for those of you who know, type 2 diabetes, ultra-processed food and type 2 diabetes do not go hand in hand. What he really needed was access to fresh fruits and fresh vegetables, and that is exactly what Fresh RX has done for him. It has given him access to fresh fruits and vegetables, and it provides free and healthy food to those patients who qualify for its benefits, like patients like Merlin that have type 2 diabetes. And it enables the participants in the program to actually take control of their health. And so what Merlin told me is, look, Liz, this program has changed my life. It has enabled me to take power. It has enabled me to be in charge of my disease and my challenges. And on the same time, one thing that I don't know that Merlin knows, but it's actually benefited the city of Tulsa in 4 different ways. First, it's obviously led to better health outcomes for people like Merlin, but it's also done things like economic impact. For every dollar that it's saved, the community has saved, it's invested $1.70 in its community because FreshRx actually sources its food for this program locally from local Tulsa-based, Oklahoma-based farmers. And as a result, third, it's actually created local farmer stability. I had a chance to meet one of the farmers. Her name was Kat, and she said, Liz, this is incredible because it's actually given me and my family more income stability, more economic stability, the chance to do more for my kids and my family. And then also just the fresh fruit access. It creates more fresh and healthy food throughout Tulsa. And so it's this kind of work that we aim to work with AHA and communities across America to make sure that we give that chance to communities to change lives and to get power back into the hands of the individual. And so you might want to ask, why food is medicine? Why does the Rockefeller Foundation care? So first of all, as you can see in this chart, a growing number of Americans are facing challenges from chronic health disease. And 129 Americans actually suffer from chronic health disease, of which 75 million have 2 or more chronic health diseases that they are suffering from. And I know I don't have to share this with you. The Black community, as you can see here, suffers from it disproportionately relative to other communities. The other thing that we're wrestling with, and I know Kevin will talk about this even more, we are really, really good at spending money on health services, and we are really bad at actually getting health outcomes. And that lack of nutrition is one of the #1 drivers of poor health outcomes in America. Diet-related diseases cost us $1.1 trillion in extra healthcare costs a year. And that's more than some countries spend on their entire food budget. We've got to change this, and that's why for us, Food is Medicine is a real opportunity to link all of these things together. And so for the last 113 years, the foundation has been very focused at driving well-being for communities across America, across the world. And so at the same time, one of the things that we continue to neglect is the role of food in driving up healthcare costs, in driving up poor health outcomes for our communities, and we want to change that. And the work that Kevin will talk about and the work that AHA and our partners are doing are demonstrating how Food is Medicine is changing those outcomes for Americans. And so just to give you an example, the Cleveland Clinic actually tested a medically tailored meals program and found that patients required fewer emergency visits, which means $12,000 in savings per patient. That's real money. And if we actually implemented national produce prescription programs, we've seen through the evidence that we could avert almost 300,000 cardiovascular deaths and add 260,000 years to people's lives. That's real lives and real money. And so that's what makes FIM different, and that's why we care and we believe in the power of food as medicine. And that's why we're part of this broader idea on making food as good food for all, and we're supporting the American Heart Association on this. So we've committed $100 million to advance food as medicine with a real focus on these 4 key areas. Better evidence, making sure we have the research and evidence to demonstrate that this is actually something we should do. Better policy, providing technical assistance and guidance to policymakers. Better infrastructure, supporting communities like Tulsa, Oklahoma to do the work. And better communication so you actually know how to say and how to talk about this with your communities. And then as part of that final pillar, as Lisa mentioned, we've developed 2 critical partnerships. One with the American Heart Association with this idea of Healthcare by Food initiative, and Kevin will talk more about it. And second, with the Veterans Health Administration to make sure that we support our veterans because veterans suffer from chronic disease 25% more than the ordinary population. And we've seen in that population higher uptake, better health outcomes already. We're already working and supporting 5 different states to be able to support this. And so just looking ahead, I kind of wanted to share this with you. We know the promise of food as medicine, and we need policymakers and advocates and supporters like all of you to help champion the opportunity here. And I wanted to share this data with you that we just supported and published. It's good policy and good politics. Our data shows that over 90% of Americans would prefer to rely on healthy eating than medication. And almost 4 out of 5 Americans believe that food as medicine interventions should be covered by public and private institutions. So you can pull the report online just to take a closer look at it, but we wanted to show that there is, out of 36,000 Americans polled, that there is a lot of momentum and opportunity in the constituents and communities with which we work and support. And so I'm looking forward to hearing from you and learning from you how we can continue to help support the progress and momentum around food as medicine. And with that, I will turn it over to my partner, Kevin.
Well, first of all, thank you to all of you. No worries. Thank you to all of you for being here and your shared interest in us collectively doing what we can to improve diet and health for all Americans. And I also want to especially thank Liz and the Rockefeller Foundation for their support and partnership, which is making a lot of this work possible. So I'm going to talk a little bit about food as medicine as a paradigm shift. And part of why this is important is what Liz alluded to, that the U.S. spends a lot more than any other country on health care, but we rank very poorly on a number of different health metrics. And in particular, life expectancy, we rank 48th in the world. So there's a lot of room for improvement. And a lot of this has to do with food, because Americans have very unhealthy diets, but food is very central to health outcomes. So we can think about all sorts of different parts of the body where food plays a very key role. Some of them, it's quite obvious, like diabetes, what you eat affects your blood sugar, and others might be more subtle to people, and people may not realize that it actually affects your brain health too. So lots of different evidence on that. But sadly, Americans don't have very healthy diets, and experts have estimated that about 45% of deaths from cardiovascular disease, from stroke and diabetes are associated with suboptimal diets. So lots of statistics to point to. I'm just going to highlight a few. Only 1 in 10 Americans meet recommended fruit and vegetable intake. 2% meet whole grains targets. More than 9 in 10 have excess sodium intake, and Americans consume, on average, more than 60 pounds of sugar a year. So all of this is contributing to the population being much less healthy than it could. Americans actually realize this to a large degree. So when you poll, as we did in a national survey with Research America and Deloitte, when you poll Americans, 77% say they would like to have healthier diets. But the number one reason people give for why they don't have a healthier diet is affordability. And sadly, this often comes into play with people who have children who are balancing paying the rent and buying cheap, unhealthy foods versus healthier foods that are more expensive, or with senior citizens who are trying to pay for their prescriptions and trying to balance that with the cost of food. So to level set, I'm going to say a few words about what food as medicine is, just to make sure everyone understands the concept. And in essence, it's the provision of healthy food resources to prevent, manage, or treat specific clinical conditions in coordination with the healthcare sector. And we created this Venn diagram to try to help people see, on the one hand, we have food and nutrition assistance programs, which for decades have been really critical to supporting Americans. They tend to be income eligible, and programs like SNAP and WIC are great examples of that. And then on the bottom of this diagram, we have population-level healthy food policies and programs which support health for all Americans. So things like food labeling, or trying to do sodium reduction as part of what's part of ultra-processed foods. Those are programs that benefit everyone. Food as medicine is a little bit different. It's really targeted based on specific clinical conditions, and it's intended to be paid for by the healthcare sector as a healthcare program. And then, of course, there are some people who might be eligible for both. So when you look at surveys, like Liz alluded to the Rockefeller Foundation survey, Americans really like the concept. More than 4 in 5 believe U.S. healthcare should offer food and nutrition programs to treat and manage disease. Nearly 9 in 10 would prefer to rely more on healthy eating rather than medications to manage their conditions. And I want to highlight in the middle here a very interesting statistic. 85% of self-identified Democrats, 78% of Republicans think food as medicine programs should be covered by public and private insurance. So moving forward then, I think one of our central challenges is that our healthcare system hasn't really tried to address food as medicine, or for that matter, nutrition. Physicians in general are not given a whole lot of nutrition education as part of their training. In past decades, it was often only an hour or two, believe it or not. And so what we did in this presidential advisory for the food is from the AHA is we really tried to describe the problem and understand what are the limitations of the evidence, what are the opportunities in terms of what to improve. And I'm going to give you a few examples from that. One is of the potential power of food as medicine. So heart failure is the most common cause of readmissions for Americans over age 65 in the United States. But in a recent study, 45% of people discharged from hospitals with heart failure had moderate malnutrition, and 30% had severe malnutrition. And this is a shocking statistic. You might wonder, how is this possible? Well, for 20 years, I was a clinician at the VA, and I'd see this happen time and time again, where conscientious patients were trying desperately to keep their weight stable because they were instructed by their clinicians, pay a lot of attention to your weight, because as your weight goes up, your ability to breathe is going to be compromised. Obviously, everyone wants to breathe, so you pay a lot of attention to your weight. But if you're having a diet that has a lot of ultra-processed foods that's not nutrient-dense, you become progressively malnourished. And that's in essence what's happened to a lot of Americans with heart failure, and probably why pilot studies that have been done show enormous impact, 40 to 60% reductions in readmission rates. And if this were a drug and there was a payment model and a profit motive, I think it's probably safe to say that billions of dollars would have gone into further research and innovation to accelerate widespread dissemination. But because there's no payment model, this has not moved forward at the rate you'd expect for something that could help so many people. So that's the gap that we're trying to fill, really thinking about where is there evidence like this? How can we build on it? How can we make it more solid? How can we convince people of the cost effectiveness of these programs? And how can we use that to convince public and private payers to pay for these programs to help improve people's health? Some of this is using human-centered design. That's a big emphasis for us because we want to design programs that are engaging to people, that meet them where they are, and that really tap into their lived experience. Some of it is behavioral science, like really trying to think about how do we help people change their behavior, since none of this is easy. And then some of this is really thinking about the rigor of studies and trying to do them in such a way that people believe the results. We have started this initiative in the last 2.5 years and gotten a lot of programs going. We have about 25 clinical trials around the country. We have another 10 planning grants. And then we're also working with a number of state Medicaid programs and private insurers on trying to accelerate the creation of better evidence. Our focus is on building on the existing evidence and really focusing on where are there gaps. So if you were a doctor that wanted to prescribe a program, if you're an insurer that's interested in covering a program, what do you need to know about who should be eligible? For whom are these programs beneficial? For whom are they cost effective? What is the optimal dose, the density, the duration? What should these programs be combined with? And our focus is really on populations that will benefit the most from these programs. We know diabetes, hypertension, high-risk maternity, cardiovascular disease, extremely common, sadly, more common in Black adults in general. And this is where we need to make more progress faster. I mentioned we're doing a lot of innovation in Medicaid. The federal government is allowing states to use federal dollars and state Medicaid dollars on an experimental basis for programs like Food as Medicine in the states in orange. The states in yellow, it's pending. And then the states in green, they are doing lower level experimental pilot or demonstration projects. We're now working with a number of these states around the country trying to help them design more effective programs and do what they're doing more effectively. We work with a lot of public and private sector partnerships. We think all of the above is critical to moving this forward, and we look forward to discussing this further with all of you and answering your questions after Lisa moderates the upcoming session. Thank you.
Thank you, Kevin. Thank you, Liz. Now we're going to move into just a little bit of facilitated discussion and open it up for our audience to ask questions afterwards. Let's start with the first question to both of you. How do you see FEM being particularly important for communities of color?
Well, let's start with some of the underlying statistics I mentioned. Diabetes, stroke, heart disease, kidney disease disproportionately affect communities of color. And I think FIM programs have the most potential to benefit people when there are higher rates of chronic conditions. And we can move faster. I think we could do a lot to improve outcomes in those communities if we can bring healthcare dollars into the mix where affordability challenges are relevant. That's going to make a big difference because, as noted, people know that healthy food is better for them, but for many people, affordability is the challenge, and that's a challenge we need to help people with.
I think I completely echo what you said, and I think that's part of the need to continue to produce and make sure that we are growing food locally and culturally appropriate food. And so if I can just tack on two things, I think one is the cultural appropriateness of food, because food as medicine is only as good as actually people eating the food that they've received. And I've had the privilege, my home state is Hawaii, and so I had the privilege of seeing some of the work that has been happening in Hawaii. And I was saying to one of the partners from AHA that in Hawaii you eat ulu, which is a breadfruit. That probably doesn't play well in New York City, which is where I currently live. But when we were in Tulsa, the key part of the food basket was, and the recipes that the community was getting was around succotash. So I think there is a culturally appropriate, relevant, local production value chain that is part of the equation. And then, as you said, Kevin, I think there's just a need to recognize that so many Americans, and especially as we saw on the graph, there's a lot of ethnic disparities where certain communities, especially the Black community, has a higher incidence rate of 2 or more chronic diseases. This is where we need to make sure that we help support access to good quality, healthy fruits and vegetables so that we can improve people's diets and quality of life.
Absolutely. I echo everything that both of you have said. Food as medicine is a novel approach. It's very innovative, but it's a lot of challenges to make it reality. So what would you say the current state of the food as medicine movement is, and what do you think we need to do in the future, now or in the future, in order to make it a reality for everyone?
I think we've moved rapidly to try to consolidate some of the existing evidence, and there's a lot of very promising initial evidence. But what we need is much more systematic evidence for specific clinical conditions. So if you think about the looming challenge, the biggest looming challenge is having a payment model for these programs, because it's ultimately a question of affordability for a lot of people. And so to convince insurers, we need to be able to say, let's say a program of medically tailored meals would help patients with heart failure after a hospitalization, because we know there's very high malnutrition rates. Who's eligible, for how long, how many medically tailored meals a week, and what is part of the program? Is dietitian counseling part of the program? Are there other support services? Mapping that all out systematically is really what's needed right now. There are programs and studies that are being done, but we need more of them. We need more of them in different populations. They need to be culturally tailored, and we need to figure out in other clinical contexts in parallel, how do you test all this, and how do you figure out both short-term, long-term, how do we help people increase the rate of healthy eating in ways that are cost-effective?
I'll just add on to, I think is like Kevin, exactly, I think that's exactly what we agree with. I think there's 2 really big pieces. One is the research that I think that you mentioned, and building that evidence base to demonstrate the value proposition that food is medicine brings. One of the things that the foundation I mentioned is supporting is some work with the Veterans Administration, working in 5 different states. Let me make sure I get this right. New York, Maryland, Utah, North Carolina, and Texas so far, because we see the higher incidence rates of chronic disease with veterans in particular, in addition to the work that we're supporting with AHA, and this need to do that applied research so that we build the evidence base that policymakers can use to help shape policy that works for communities. And then I think the other piece is around implementation support. I was just speaking with one of our partners from AHA earlier, and Medicaid is one of the biggest opportunities that we have out there to be able to drive progress here. And there are millions of people who aren't being reached, who suffer from this chronic disease burden. And so I think those are ways that we can help support implementation and make sure that we're actually reaching the communities that need and deserve to be reached.
Thank you, Liz. So let's transition a little bit, because in both of your presentations, you talked a little bit about cost, but you also talked about the pervasive need to implement FEM in real-world settings. So I'd like to ask you both to explain or give us a little bit of context about what is meant by food as medicine programs being effective and cost-effective, and why those two different parallels are so important.
I think the cost thing is so up your alley. You go for it.
Okay. So the first question with all of these programs, if you think about any health intervention, the purpose is to improve people's health. And that's really the starting point. So in thinking about these programs, the question is, what is effective for whom in improving a relevant health outcome? So we could think about, let's say, diabetes. Is the program effective in lowering your average blood sugar or your hemoglobin A1C? Question one, and you could argue full stop, that's all you need to know, because when medications are being tested in clinical trials, that is the only question they're trying to answer, and if they answer that question successfully and the benefits are greater than the risk, it gets covered by insurers. However, as a program that's not a medication, interestingly, a lot of programs that relate to health behavior, lifestyle, prevention, there's this curious double standard where the health system wants them to also save money. And it's a little bit of an unfair double standard that we're trying to push back on. But obviously, the more cost-effective these programs are, if we can show that they're not only effective in improving blood sugars, but they also are as cost-effective, meaning they achieve similar effects for lower cost than currently covered interventions, then it becomes very hard for insurers to say no to covering the program. So that's in essence what we're trying to do, is first show that they work, and then second show that they can deliver those outcomes at a cost that's very reasonable compared to things the health system already pays for.
Thank you. So at the core of what we're talking about, it's food. There's a lot at play when we're talking about food, and food is personal, food is cultural to all of us. So Liz, I'd like to ask you to talk a little bit about the importance of the food ag component.
I'm happy to. So, the foundation obviously has been working very closely with the Healthcare by Food initiative on the research agenda and making sure that we continue to support the evidence base. At the same time, I think, Kevin, you've talked about the importance of affordability, and one of the challenges that we see is just the food sourcing and agricultural development and opportunity. One statistic that always sticks with me is that the average age of the global farmer is 65, and yet our global population is growing, and it's not necessarily feeding the people and reaching the people that we need to with quality nutrition. And so the foundation and we and my partner Dana here have been supporting this idea of what we call FIM Plus, where we work with communities, and communities communities that are already working on food as medicine to try to help link up the food as medicine, produce prescription boxes, medically tailored meals with the local agricultural economies. Because what we've seen, at least on the early days, is when you're actually closer to food, it contains more nutrition. And at the same time, it benefits the local economy, it benefits local farmers. And so, in Tulsa, for example, because the program that FreshRx is delivering both links up to people like Merlin and gives him local food, local recipes, the surround sound supports that he needs to strengthen his personal health, it also ties up to the local farmers. And many of those smallholder farmers that actually do supply FreshRx are women. And in that moment, in that connection, it gives those smallholder farmers that are based locally a stronger, because of the link with a specific procurement contract, it gives them economic certainty. It gives them access to opportunity that they don't have. And our measurement so far shows that for every dollar we saved, $1.70 actually gets reinvested into the local community. And so it's a really beautiful virtual cycle that we can create by improving affordability, making people's lives better, both through health, but also through economic opportunity.
Thank you, Liz. Very passionately said. Dr. Vogt, I'd like to ask you to build a little bit on what Liz has shared, but maybe take it a step further and talk about the role that community-based organizations can have in implementing food as medicine programs.
Yeah. Community-based organizations deserve a lot of the credit for the whole food as medicine movement coming to be. A lot of them have been meeting the needs of Americans who struggle with not having enough food to eat or not having access to nutritious food for decades. And they know communities better than anyone. So trying to figure out how to leverage that and build on that and work with them has been an important part of what we've been doing. AHA's Healthcare by Food initiative is working with about 25 community-based organizations around the country, and they provide a very important foundation for a lot of the work going forward. And I do think that one of the strengths they bring is they have a very deep understanding of a lot of the cultural norms and preferences of different communities in a way that corporates may not. But corporates, of course, also bring other strengths. And so we're trying to figure out, how do we leverage everyone's strengths to create the strongest possible ecosystem? But the community-based organizations really deserve a lot of the credit for bringing food as medicine to the fore.
Very nice. Thank you both. I'd like to open it up to the audience for any questions that you may have for our panelists here.
Hi, good afternoon. My name is Chanel Foster, and I have a group mental health practice in Hawaii. I'm also in California doing some work with UCSF in neuro-oncology. I'm really fascinated by this. I love it. It does feel like a long time coming. I'm wondering how I, as a mental health clinician, can participate. I'm not able to prescribe psychotropic medication, but can I prescribe food? Is there a way forward for mental health clinics to also work with individuals? Because as you know, diet is behavioral. And I find in my practice, a lot of my patients, and I am a community care provider with the VA, a lot of my patients need that holistic approach to their mental health so that they can change their behavior, they can know why they're doing it, and in the process, reduce their risk for chronic disease. Thank you.
Thank you for your question. What you've described is a big part of our vision. We would very much like you to be able to write a prescription to any of your patients who would benefit from such a program. What we need before that is for insurers to agree to pay for the programs so that your patients will have at least subsidization of the cost of healthy food. And that's what we're driving hard towards, working both with public and private payers to try to get to that point. Totally agree with everything you said. There's a lot of potential benefit for our patients, and We just need to convince the rest of the healthcare sector that that's true and that it makes sense to cover these programs.
Thank you.
Thank you.
Hi, good afternoon. Sorry about that. My name is Jay Wilson. I'm the founder of Melanated Moms. I'm also the executive director for Connecting Our Communities for New Jersey. We're a coalition that specifically looks at Black and brown families between the period of prenatal care to age 3 of the child. So all of our work is really rooted in maternal health and improving outcomes. So my question for you is, how do we have more conversations with maternal health clinicians around how to prescribe food as medicine to add to improving birthing outcomes, honestly?
This is another great question. Thank you.
You're welcome.
We agree this is a critical area. So about a third of the studies we fund are in patients who have high-risk pregnancies, because as you're pointing out, it's just critical for the health of the mom, for the health of the baby, and part of why we focused on that is this is an area where we're at least guardedly optimistic. It will be easier to convince insurers of the economic case for this because pregnancies last a certain amount of time, and we're not talking about over a period of many, many years where they would see that immediate return. Ideally, we would all be focused on the long term, and we'd be investing heavily in kids, but insurers consistently are focused on short-term returns, and high-risk maternity is one of the most clear areas where it makes sense to invest more, and we'd very much like to be able to do that to enable clinicians to write those prescriptions.
Yeah, our medical director, her name is Dr. Natasha Chen. She's triple boarded OBGYN, maternal fetal medicine, and integrative health doctor. And she actually just wrote a book literally called Food is Medicine. So I was like, I have to ask this
wonderful.
question. Yeah.
Well, look for that.
Yes, please do. But she's been trying to have this conversation with her other colleagues of here's how we integrate what we're doing so it can have long-term benefits, because moms who have preeclampsia or gestational diabetes now are starting to see long-term or even lifelong chronic illness that's impacted. I'm even one of them. I'm a 4-time survivor of preeclampsia. I still have heart conditions now, and I'm 156 months postpartum, right? So, like, how do we have that conversation in that clinical space where other clinicians, not just the OB, but the other people who are a part of that healthcare team, primary care, endocrinology, whoever, understands this is also a part of how we collectively heal?
Yeah,
Sorry, that was 2 questions.
These are such important points, and our goal is to make this part of standard medical care. So it's just part of what we do. You know, we want to prevent preeclampsia, we want to prevent gestational diabetes. Let's pull out all the tools that we have that can help make that a reality. And we really think food as medicine programs are part of that solution. We just need to convince the payers of that.
Thank you.
Thank you. The only other thing that I'd add to build on what you so eloquently stated is that it's the importance of partnership, education, and building championship so that people understand what food as medicine is and isn't, and how there's so much tremendous potential for incorporating it into the healthcare delivery system. So hopefully you've learned something here today that you can take back to your practice.
Absolutely. Thank you.
Well, do you mind? I just wanted to add one more thing on. I'm like always the one more thing person. I think it's interesting as well. I mean, what you shared, I'm really glad. I wondered, Kevin, maybe if you would be able to share kind of the pillars or the conditions that you are looking at so that our audience knows what they are. And then I just wanted to add on top of it, thinking on the fly, there is power in convening and making sure that this information gets to the right hands and people and into the convening spaces and into the dialogues by which you engage regularly. And I know we will continue to come out. Kevin will be able to share some of that research. So perhaps after this, if you can kind of share who you connect with. Once we have more quantitative evidence that you can share, we can help kind of make sure that it gets into the right hands and people so that it kind of self-perpetuates through the communities we need to reach. But back to you, Kevin.
So I mentioned that about a third of the work we're focused on is high-risk maternity, and then we have another significant portion that's related to heart failure and readmission prevention. And then I would say the bulk of the rest of the portfolio is focused on cardiovascular, kidney metabolic. So this is diabetes, hypertension, obesity, and really thinking about the role food as medicine can play in reducing the risk of those conditions and the risk of down-term health bad outcomes.
Thank you. Next question.
Just gotta take it a minute down. How you guys doing? My name is Stacy McAllister. I'm a founder of a nonprofit in Los Angeles called 511 Hoops, and what we do is we service neurodivergent kids and adults through sports and social programs. One of my biggest things I like to preach to the parents is like healthy, good food helps with the behavior and development. And my question is, has research specifically measured whether improved access to fresh produce can help autism-related behaviors or improve developmental outcomes?
It's a great question and an important one that we don't have an answer to yet. We have been doing some work now, starting with type 1 diabetics in kids, but because of the laser beam focus on trying to get insurance coverage, we've mostly focused on healthcare conditions in adults that are expensive to treat today. I think, as you point out, there are a lot of other really, really important priorities that should be studied, and if we can convince the federal government and others to put more funding into this, I think we could move forward much faster with doing a lot of that work in parallel, which would be really useful.
Thank you.
Hello, hi. Thank you all for this talk. I'm Mariah. I'm a community doula. I'm also a state maternal health federal policy with March of Dimes. And so, for those of you who don't know March of Dimes, we do infant maternal health, some of which include the conditions that you mentioned. But to keep it short, you mentioned that for your programs, you use a combination of Medicaid populations. Obviously, Medicaid covers 42% of births in the United States, so it's important. Also, those 1115 waivers, which allow demonstrations, very vital when you're just testing ideas and you're trying to create a proof of concept. You also mentioned in lieu of services. I'm just going to point out the elephant in the room here, if it's okay. And if you can't answer, that's fine. We have a reduction in Medicaid. States, particularly, are going to have less or fewer dollars, particularly ACA expanded states, to be able to experiment and be able to run some of these amazing programs. So I think it's a two-part question. Feel free to pick whichever part speaks to you more, but it really highlights the importance of philanthropic and state-based relationships, because as we've seen, as the dollars decrease, states are not going to be able to, basically shovel out more funds. So we'll need things like the Rockefeller Foundation. I myself was just a recent graduate of a wonderful program called WANDA in DC. I also work in DC, where we have one of the highest maternal mortality rates in the country, and it's predominantly Black. So when you're looking at WANDA, which focuses on maternal food as medicine, we create culturally sort of congruent agricultural and nutrition diet plans for mothers who are either in postpartum or people giving birth who are pregnant, who we know are higher risk. But the issue often that I see as a doula is I've seen clients go into a hospital 3 days before delivery and all of a sudden be told they have hypertension. So while I think it's great that you're focusing on high risk, that's not something that's always screened for. I mean, I also work as a doula, and maternal mental health conditions are also not universally screened, because another conversation about how we should institute and force providers to do universal screening for maternal mental health conditions, not just when people are dying or they're at risk of getting a maternal mental health condition or some other awful outcome. So in a perfect world, yes, we would screen, we would know who people are high risk, we'd be able to treat and link them to wonderful programs like this. But for most of us, including Black women and birthing people who are not, I fear that there's just going to be less on the table. And so while I'd love to see the expansion of programs like this, particularly in a city like DC, I'm from Appalachia, so rural health, another problem. How can we get philanthropic partners to the table? Also, you mentioned insurers. It's difficult to get them to create billing codes for maternal mental health conditions because they need proof of concept, but without money, I can't provide your proof of concept. Without a demonstration waiver, I can't convince Aetna, Humana, or any other private insurer to want to invest in this, so it creates this really negative feedback loop. How can advocates, folks who work at organizations like March of Dimes, people who have the wherewithal to do some lobbying, advocacy, how can we work with you all? And how can we get insurers to be willing to be brave to experiment when, again, there's not enough of a capacity, right, to say, hey, these programs work, and let's get them before they're high risk, because we know this population tends to be, unfortunately, impacted by our health system, like namely Black people, folks who are in lower income areas.
So that was a lot. So let's try to, wonderful. Let's try to unpack some of this.
Please, let's.
So you bring up a really good point about Medicaid and the cuts to Medicaid. I will say this, that American Heart Association has had a long-standing history of protecting access to care through Medicaid as well, and that doesn't change. Food is Medicine really builds on top of that. There won't be Food is Medicine if there isn't any Medicaid. But the same is true for other programs such as SNAP and WIC, other very critical programs that are nutrition-based, food-based programs that help solve other problems. So that's where the statement that Kevin made about the complementarity and how Food is Medicine sort of lives in that interstitial space between all of that really comes to life. But what we're talking about here are three very focused interventions: medically tailored meals, medically tailored groceries, and produce prescriptions, because that's where the evidence really shows there to be a greater value add to improving conditions, chronic conditions, which is what we need to focus on in order to show that apples to apples comparison, if you will, with pharmaceutical interventions that treat, manage, and prevent diseases. So if you think of it in terms of Food is Medicine, sort of shifts towards the landscape of how can we work with providers in general to really look at food as a treatment mechanism to improving conditions. So as you spoke so very eloquently about high-risk maternity and just maternal health in general, that's an area that has been on our radar for quite some time, because a lot of moms, that's their first introduction to the healthcare system, and then they find out there are other conditions that frankly need to be treated pre and postpartum. And so that's where building that evidence is so very critical, to really understand not just how these interventions can effectively treat that, but in what way. Is it 6 weeks of an intervention? Is it a certain caloric intake? So there are a lot of secondary questions that are really critical to really root that behavior change that's needed to improve the health and also sustain the health postpartum. So that's one thing. The other question you bring up was around really that public-private partnership. I'd love to ask our panelists to just kind of share some perspectives around that.
Sure. I think, first of all, thank you for sharing it, and thank you for making sure that our moms and babies are well taken care of. I think that's really important. One of the things that I think that we have really been trying to work on is figuring out how to link our work to the communities that we serve, and that we listen and learn, and that we develop programming, and that we develop convenings and support to those. So I guess I just wanted to say thank you, because I think, as you said, Lisa, like our intervention has primarily been on Food is Medicine and elevating elevating the research and making it a priority to tip the system, as you said, Kevin, on insurance, and make sure that it's a covered benefit. And perhaps just hearing from what you're saying, it will help inform, as the foundation, where we look and how we partner. The other thing that I think is critical, and I know we kind of talked about public philanthropy, I think there's also a markets part of the work. And Lisa, I feel like the team at AHA has been incredibly proactive at making sure that we connect with the groceries, connect with companies like Instacart and Kroger and others who can access and have physical footprints there. And so that's where we, as philanthropy, as the private sector, as policymakers, can all come together to drive the health outcomes and to make sure that it's affordable. And I think we're very proud to support that and make sure that it reaches communities as well.
And I want to speak to a third part of what you talked about, which is really critical, which is how do we unlock this payment piece?
Mm-hmm.
Because without that, all the patients who would benefit and all the clinicians who want to prescribe won't be able to do that. And in essence, I think in a perfect world where we had longer time horizons, we would be focused on health and nutrition and prevention for everybody. But where we have been able to get the attention of insurers is by focusing on patient populations who are expensive to take care of now. Now, unfortunately, that means there's a lot of damage done. Patients often have multiple chronic conditions. They have complications from those chronic conditions. But that said, there is the possibility of changing their trajectory and in very beneficial ways. So I mentioned studies showing reductions in the need to be rehospitalized if you're a heart failure patient by 40 to 60%. So dramatic for each of those patients. And those are the kinds of settings where we've been able to get the attention of insurers. They're not philanthropy, but they do have a self-interest from an economic standpoint in figuring out how do we reduce costs going forward, how do we improve health while preserving or keeping costs as low as possible, trying to figure out what for them checks the boxes they need to check, and where can the evidence support that is a big part of what we're trying to do. So it's really, for now, a lot of the research is focused on the clinical populations who are costly to take care of, because those are the people who, in essence, are hurting most, and where we think in the near term we can have the most demonstrable benefit.
Yeah, thank you. I think I'm just thinking in terms of maternal health. I know that there are people beyond reproductive age that also suffer from chronic health conditions, so I'm appreciative and sensitive to that. I suppose I wanted to know, maybe we can talk offline about how you are getting insurers to even be curious about how that model could be appropriate for the maternal population, birthing people, postpartum, whatever, some of whom also have heart conditions. As the previous respondent mentioned, she has a chronic heart condition as a result of her preeclampsia. So I think these are ideas to think through, but I appreciate your time and thank you for the thoughtful responses.
Yeah, I do want to mention that in terms of high-risk maternity, there are a number of populations that we have projects in where we think there is alignment potentially between what we, the public, might care about, what public health experts care about, and what insurers care about. So it's women who develop preeclampsia, gestational diabetes, women who have diabetes when they become pregnant. There are a variety of different conditions where clearly there's significant elevated risk to the fetus, where if we can help the woman have access to healthy food, we believe there could be a demonstrable benefit, which is measurable and which insurers hopefully will thereby be interested in covering in the future.
Fingers crossed. Thank you.
Yes. I think we have time for maybe one more quick question before we have a special guest that I think will be joining us fairly soon.
Hi, my name is Dr. Angela Bully. I'm a board-certified internist from Detroit, Michigan, in practice for 20 plus years. And what I know is that I take care of probably every last one of the chronic diseases that you had on your slide. And my question is, insurers, they are very good at collecting data, especially with chronic diseases. I'm responsible for a lot of that, and a lot of insurers model themselves after what Medicare does. So have we gone to Medicare and tried to get insured? Because I can see they collect the data for chronic diseases, but I'm not really sure what they do with the information. So that's one. And my second question is, how would a provider become aligned or participate in your clinical trials?
Great question. So in terms of Medicare, we are in active discussions with CMS, who runs Medicare, about ways to test these programs and support the broader scale testing of these programs. There's also been a lot of discussions with private insurers about the Medicare Advantage patients they cover. So I think there's potentially some significant alignment as well. In terms of interest in participating in clinical trials, we don't have a great mechanism for that right now. We do have, I mentioned 23 trials around the country, but we basically let that develop organically with investigators throughout the country and partnerships they had cultivated. But we will give that some thought. I think it's a really good question. How could we facilitate enrollment in programs by clinicians who are like-minded and want to be supportive of creating better evidence? So thank you for asking that.
You're welcome.
Thank you all so much. This has been such a rich discussion. We really appreciate all of the questions you guys have. We have some experts that will be available to answer any additional questions you have, but before you leave, I do want to introduce our special guest, Representative Gwen Moore. Congresswoman Gwen Moore was elected to represent Wisconsin's 4th Congressional District in 2004, making her the first African American elected to Congress from the state of Wisconsin. She's a member of the esteemed House Ways and Means Committee, which is the oldest committee in the United States Congress, and has jurisdiction over Medicare, which would include food as medicine, as we've talked about today, as well as the Social Security system, the foster care system, temporary assistance for needy families, unemployment insurance, and all taxation tariffs and revenue-raising measures. She also serves as co-chair of the bipartisan Congressional Preventive Health and Wellness Caucus, which has food as medicine as a priority. So I'd like to, oh, she's not here? I'm sorry. We were going to introduce her. I thought she was here. Are we good? Okay. Well, if she's able, she will join us shortly. It looks like we might have time. Okay. Very nice. Well, I don't know if she's going to be able to join us, but I do want to thank all of you guys for giving so very generously of your time and listening to us talk about food as medicine, where we really see the future of health going. Thank you all again so much, and please, by all means, hang around and ask some questions of the experts.